Hi, everybody. This is Dr. Mike Carberry with Advanced Medical Integration. Welcome to daily.amidoctors.com. Let me explain what we're doing. In the midst of this crisis, the coronavirus crisis, I'm 58 years old. I've never seen anything like this in my whole life. This is as close to well, it is a pandemic, but a plague. It's as close to a plague as I think we can come without actually having a plague. Some people would argue we are having a plague. I would say we're having a cold. But, you know, I'm not going to downplay the whole thing. It is fatal to some people. That's not good. We want to minimize the contagion of it. We do know that this is very contagious, but what's happening is we're shutting down the country. And even worse, Americans are shutting down in their mind what we can actually do as a country. So I want to let you know that I personally disagree with the idea of this whole thing in the universe. And I'm not saying I disagree that it exists. I'm just saying if we all disagree, we can actually change it. You see the president disagreeing with it over and over again, and we're looking to change it. So what do you do in the meantime? You got patients sitting at home going, oh, I don't want to come in, I don't want to come in. So we've taken steps to get patients to realize actually exercise is one of those things that could boost your immune system. I mean, the lymphatic system is imperative in immunity, and the lymphatic system doesn't have a heart. The lymphatic system relies upon movement. So getting people to exercise, getting people to do the rehab would be a really good thing to do for them to boost their immunity. There's two ways you could look at this virus. You could say, oh, woe is me, I hope I don't get it. Or you could say, hey, my body is designed to resist a virus just like it's designed to resist a cold, which is a virus. And I'm going to resist this thing. And I'm going to do things to boost my body's ability to be immune to these things, to build a reaction to build an immunity without actually getting the cold, which is very, very possible. How do you do that? So what we're trying to do is minimize the spread by taking extra steps on cleanliness, following the CDC's guidelines. And we're letting our patients know that. We're bringing this information to you so you can actually do what you have to do to help your community in the midst of this catastrophe. I'll call it a catastrophe. So I'll give you a couple examples. We have clients that are going, oh my gosh, the end is near, I'm going to go broke, I have to lay off all my staff, I'm going to have to start all over again. And it's not just a couple of them, it's a bunch of them. At the same time, we have a bunch of clients going, you know what, I'm a doctor, I help people with their health problems, this is a health problem, I can help them with this, and they're actually booming in the midst of this. My clinic in Chattanooga, Tennessee, closed 6 new patients on entire rehab care plans 2 days ago. So if we can do that, you can do that. It's just a matter of how do you present your message to the public. So what we're doing is we're bringing relevant, actionable content, things you can do in the midst of this crisis, along with interviews with thought leaders in the industry that are bringing true data so that you can actually understand what's actually happening and react to it with true data, not the piles of false data are out there. I watched so much news yesterday because I don't even have cable at my house here in Oregon. So I watched so much news on the internet yesterday trying to get the true assessment. And I heard things like certain governors and mayors of cities saying, oh, this month is going to be worse than last month, and next month's going to be worse than this month, and May is going to be worse than April, and blah, 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 blah. Then I listened to the president who said, you know what? We don't want anybody to die from this virus, but we sure as hell don't want people dying from committing suicide because the economy crashed and our country fell apart, and that could be a bigger number. So he's saying we're getting back to business, and he's saying we're getting back to business very shortly. He put a 15-day limitation of activity and social interaction, and that was 10 days ago. There's 5 days left of that. And he's now saying it looks like by Easter, which will be a week from this Sunday, America will be reopened for business. So let's just focus on that. Let's just focus. But as a medical clinic in my state, I'm open. I'm treating patients. You know, we've had the warnings go out. The governor of our state said we don't want or elective surgeries being done or elective dental procedures being done. So you need to, if you do those things, you need to close. And everybody's thinking, oh, he's telling everybody to close. No, he's not. We're open for business. We're helping people. The number one thing that shows up in a urgent care or in an ER when this virus wasn't happening was chronic degenerative arthritis, specifically back pain. If we can take that burden off of the ERs and the urgent care so that they can actually get to business dealing with the coronavirus, we're doing a tremendous service to our community by relieving the system. That's what we want you to do. So we're bringing you these workshops, these videos, these live webinars to bring you this information so you can get empowered yourself and empower your community, empower your patients. So we're going to start tonight. This is Wednesday, and we're going to start it. This week's going to be a different schedule. We're going to have 60 to 90-minute episodes, and tonight is Coleen, and you'll hear from these two in a minute, Coleen and Lisa from Gold Star, and they're going to talk about telemedicine and cut through all the data. I've heard so much false data about telemedicine, and one of the biggest sources of that false data from telemedicine is coming from insurance companies. So just remember, insurance companies, they don't want you to know how to bill because they don't want to pay. It's like, you just got to consider the source. So we're going with somebody who's done all the research. Lisa's going to give you all the research about what you can do with telemedicine and how you can actually use that if that's what you decide to do. But we're open for business. We're having people show up in our office. We're going to have another one tomorrow evening, same time. They start at 5:30 Eastern, so which is 2:30 for me in the afternoon here. So we're bringing them to you 60 to 90 minutes. We're going to have guests this week. We're going to do another one on Friday, and I'm just going to let the cat out of the bag right now. John Rosa, the only chiropractor in the White House Committee on Opioid Abuse, is going to tell us what the feel is in Washington and what we can actually do to try to make a breakthrough in some of the treatments and prevention of this virus, which we hold a lot of the keys in our hands. So we're going to bring you relevant data as much as possible. Starting next week, Monday at 5:30 Eastern time, we're going to do one of these every night, Monday through Thursday. And we'll keep doing it until this crisis is over, because we know that reaching out to our group and keeping our group as a cohesive group with the true data and being able to operate off of the true data, you can actually get a lot more done and help your community in more ways than you can possibly believe. So we're very glad you're here. We're very glad we have this very tight-knit group that is here to help serve humanity and to do our best to keep our country not only healthy, but thriving as the economic power giant that it is and continue into the future. So thanks for listening and tuning in. Let's get to work. Let me bring on Lisa and Coleen so they can talk to you about telemedicine. Thanks.
Hi, everybody. My name is Coleen Carberry, and I'm super glad to have you all here with us today. We brought a guest speaker in, and that's Lisa Maciejewski, who's with us today. Hello, Lisa.
Hi, Coleen. How are you?
I'm well. Thanks for joining us today.
Oh, it's just my pleasure.
Yeah. We brought Lisa on today because there's some really relevant information that we wanted to bring out to our whole community, our AMI clients, but also just the whole profession at large. And that's the incredible changes that are happening in telemedicine. So Lisa's here with us today. I just want Lisa, take a minute and tell our audience just briefly who you are, what your company is, and why you have this incredible data for us.
Well, again, thank you so much for having me on, Coleen. And my name is Lisa Maciejewski. I am the owner of Gold Star Medical Business Services. We actually provide medical administration services for chiropractic offices, medically integrated practices, and doctors' offices throughout the United States. Our main product is outsourced billing. So we do billing we have about 80 clients throughout the United States that we do billing for. We also do billing consulting and billing training for doctors' offices. So, my philosophy is, if it's not broke, don't fix it. If you have a great billing staff and they just need a little extra training or whatever, we can do that for them. Or if you're just in a situation where you really need help with your billing, we can just take it over. So either way, we can do that. Over the years, I've been involved in the chiropractic industry since 1982. I started out as a CA working in a chiropractic office while I was in college, and stayed pretty much within the profession for a number of years, and branched out into medicine, dental, and some other areas over the years. And so I have, over the years, also gotten some certifications. So I am a certified medical coder, a certified medical auditor, a certified medical office manager, and medical insurance specialist. And then I'm also certified in medical compliance. And so So we have a really wide array of products and services that we can offer chiropractic offices and medical offices throughout the United States.
Wonderful. Thank you. Thank you very much for that. And I do know, Lisa, that you have a good amount of our AMI clients that you work with, which is incredible. So with what I'd like to actually introduce now is just take a moment and talk about what you're going to be speaking about. I know.
So today what we're going to be talking about is telemedicine. If you attended the summit on Friday, I did a presentation on a basic introduction to telemedicine. What was it all about, and how telemedicine could benefit you as a practice, how telemedicine can bring great value to your patients as they are now isolated in their homes. They can't get out to see you. Yeah. So with telemedicine, you can go see them, and that's the beauty of telemedicine. Today, what we're going to talk about are the nuts and bolts. So great. How to actually implement telemedicine in your office. So if you didn't watch the introductory on telemedicine, you may want to go back to the pre-recorded session on the introduction to telemedicine and watch that at some point. You can watch this session without it. This is not a prerequisite. The first session isn't a prerequisite for this one.
Yeah.
But we're really going to get into the weeds today. So we're going to talk about, all right, step 1, step 2, step 3. Wonderful. How do we get telemedicine going in your practices, and how do we bring that value to your patients with a very, very rapid ramp up so that it doesn't take you weeks and weeks to implement telemedicine.
Wonderful, wonderful. And to the practices out there, some of you may know, some of you may not know, but my husband and I do have a practice like this. We have a practice in Tennessee. And for us, we're out there with our clients and with all the professionals out there that have their doors still open, really servicing their community. We do have some of our patient base that are home, that they feel better to be at home than in the office. We totally understand. But we're doing whatever it takes to service our community. And a service like telemedicine in the physical medicine space, having this data is super valuable to us, because now we're able to service the patients who are at home that need our care, along with the ones that are willing to come in the office. So I'm super excited, Lisa, to have you, and so looking forward to hearing your presentation. Thank you.
Thank you so much, Coleen.
Hello, everybody. My name is Lisa Maciejewski, and I'm going to be your presenter today. I am the owner and president of Gold Star Medical Business Services. I'm very pleased to be here today talking to you about an extremely important and relevant topic right now, which is the topic that virtually every healthcare provider has on their minds, is how are we going to deliver healthcare to our patients when our patients can't come to us. And last week I taught a class, a webinar, which was an introduction to telemedicine, that went through some of the basic concepts of telemedicine and what services could be offered under the new relaxation of the telemedicine rules. That presentation is available for any of you to listen to. I will be posting that presentation on my website along with this one when it is over. So if for any reason you can't attend all of the presentation, you still are seeing patients, you've got to get to your patients or whatever, don't worry about it. I have this recording right now, and we will make sure that everybody who needs it can get a transcript of this recording. I'll also be providing handouts to you as needed, if you and also as requested. So if you need handouts for either the presentation or any of the forms that I'm going to show you throughout the presentation, I'll be more than happy to get those forms over to you. So let's go ahead and get started. The first thing I want to do is just review a little bit where we are right now with the state of telemedicine. And some of these slides you may have seen on the previous week's presentation, but if you're new and you haven't listened to anything on telemedicine, I think it's important for you to understand what is happening with telemedicine right now in our country. So prior to March 6th, telemedicine was really a very limited scope of medical practice. You could only, first of all, telemedicine was only available in rural areas to rural health clinics. In the telemedicine world, prior to March 6th, the only thing that a patient could do was if they were in a rural area, they could go to a rural health clinic, which would be considered an originating site, and call into a doctor at a remote area, and then that doctor would do a virtual visit with that patient. But it had to be done site to site. It could not be done from a patient's home. It had to have very, very specific equipment and very, very specific and a limited code set of medical services that could be provided by telemedicine. And so telemedicine was really not something that was, it has every year since its inception in the early 2000s to mid 2000s, it has gained more and more traction, and more telemedicine approved codes have been added every year, but it still wasn't where it is right now. So what happened with the national healthcare emergency due to the COVID crisis is that Medicare expanded telemedicine services significantly, not only how telemedicine is delivered, but the types of services that can be delivered. And so through this, through the telemedicine fact sheet, first of all, it expanded telemedicine significantly, all right? And I'm not going to read through all of this because, again, if you want to listen to the prior week's class, I discussed this in a lot more detail. I'm just kind of giving you a backstory now because I need to bring you up to where we are in the actual implementation steps of telemedicine. But telemedicine services have been expanded. It's a waiver called the 1135 waiver. And of course, this does come from CMS. So this waiver originates with federal programs, but I will tell you, for those of you who don't do a lot of Medicare, if you see mainly commercial patients, the commercial payers have adopted these guidelines as well for the most part. And we'll discuss, what you need to do with the commercial payers here as we move along this presentation. But essentially, there are a wide variety now of telemedicine services that can be performed. Additionally, the Office of the Inspector General provided flexibility for healthcare providers to reduce or waive cost sharing for telehealth visits paid by federal healthcare programs. And some of the documents that I'm seeing coming out of the commercial payer guidelines, they are also following the same suit. Now, with your commercial payers, you have to pull those guidelines individually and make sure that you are coloring between the lines as far as the commercial payers go. But what it's saying is that if you have patients that are under financial distress because of losing a job or a layoff or whatever, and they can't afford their cost share of the insurance payable services like a copay or a coinsurance or a deductible, that as an in-network provider, as a participating provider with Medicare, you could reduce or waive those copays without penalty. And so that's always been a huge no-no, in the medical world is reducing or waiving copays. The other thing that this expansion did is it loosened the HIPAA requirements. And so where there were very specific guidelines for the types of telemedicine equipment that could be used and the places where telemedicine could be offered, the guidelines have been completely relaxed to where telemedicine can be delivered through everyday communication technologies like FaceTime or Skype. They could be done at a patient's home versus a patient having to go to a very specific place for these telemedicine visits. The Office of Civil Rights also provided some very important language for providers on telehealth as it relates to the services that can be provided and the relaxation of the HIPAA requirements. And so this document called the FAQs on telehealth and HIPAA during the COVID-19 nationwide public health emergency. This was not present last week in our presentation, and so I'm going to share some of the highlights of that with you. So one of the questions, the FAQs, is where can healthcare providers conduct telehealth? And it basically encourages providers to provide telehealth services in a private setting, such as a patient's home, but and it discourages patients or providers from doing telehealth in semi-public settings. So, like for example, if you have a patient that is, let's say, they're in a nursing home, and you are in a public meeting area in a nursing home, there are other patients around, nursing home patients, that might not be a good place to do a telehealth visit, whereas maybe in their room it would be an okay place. But those are just some things to consider, okay? And it gives you some guidance that if it can't be provided in a private setting, it's not prohibiting it, saying that you can't do it in a semi-private or semi-public setting, but it does say that you probably should get patient consent, or document exigent circumstances as to why you can't do this in a private setting. Also, it lets you know that you should continue to implement reasonable safeguards to limit incidental uses or disclosures of PHI. And so it talks about that. The other thing that it talks about, which is even more significant, is instead of the telehealth services being limited to a certain code set or a certain type of code, which in the CPT code book, in Appendix B of the Appendix P of the 2020 CPT code book, there's a list of approved telehealth services. And if you go to the CPT code book, the CPT code book has approved CPT codes that are already approved for telehealth, which have a star next to the code. So like last week, I said, look for the star. Well, this OCR communication now says that all services that a covered healthcare provider in their professional judgment believes can be provided through telehealth in the given circumstance of the current emergency are covered by this notification. This includes diagnosis or treatment of COVID-related conditions and diagnosis or treatment of non-COVID-19 related conditions, such as review of physical therapy practices, mental health counseling, or adjustment of prescriptions, among many others. Those words, review of physical therapy practices, all of a sudden open up a whole world of telehealth medicine to the chiropractic and the physical medicine practices that are listening to this webinar, okay? And so this is what we're going to be talking about. So when does the notification of the enforcement discretion expire? And that's another important question, one that a lot of doctors are asking me is, okay, how long is this going to last? And right now, the notification of enforcement does not have an expiration date. And again, remember guys, all of this is extremely fluid. So if 2 weeks from now, the the COVID virus significantly dies down and the president feels that this is no longer a public health emergency, it could be that they lift that designation and then all of this goes away. But for now, we don't anticipate that this is going to go away in the foreseeable future. I'm thinking that at least by the end of the year, although I'm just kind of being a prophet here, but I'm thinking that this will be in place at least through the end of the year. It might be sooner than that, but again, who knows? We will keep you posted as we get updates on this expiration of this new world that we're living in that is going to allow us to provide telehealth services for our providers. The other thing that this OCR communication gave us a little bit more clarity on from it even last week are the types of remote communication products that you can use. And they call these public-facing remote communication products. And they give you examples here, such as Apple FaceTime, Facebook Messenger, Google Hangouts, WhatsApp, or Skype. It could also be commonly used texting applications such as Signal, Jabber, Facebook Messenger, Google Hangouts, WhatsApp, or iMessage. Typically, the reason why these are considered acceptable is that they employ end-to-end encryption, which only allows an individual and the person with whom the individual is communicating to see what's transmitted. Now, it does give you some guidelines on what are called public-facing products, and these are the ones that you would want to avoid using if you're going to use telehealth services in your office. TikTok, Facebook Live, Twitch, or a chat room like Slack are not acceptable forms of remote communication for telehealth because they are designed to be open to the public or allow wide or indiscriminate access to the communication. So be aware of that. Facebook Live is not something that you're going to want to use for your telehealth services, okay? You want to stick with FaceTime, Skype, iMessage, things like that, okay? So just be aware that there's been a little bit more clarity since last week given as to what kind of telehealth platforms we can and should be looking at. So with all of that said, let's really get into the weeds of this and talk about how we're going to get started and what we need to do to implement telehealth in our office. So the first thing we want to do is identify the patients that we already have in our office who could be candidates for telehealth services. These would be patients who are under active care right now and are receiving rehab in the office, patients possibly who are not under active care, but as you go through your patient lists, you can identify these. These are the ones that come back every 2 to 3 weeks with chronic low back pain. You know, they can't stay away from you for more than a month. You know, they have issues that where if they do not receive chiropractic care on a regular basis, they're going to have a rapid deterioration in function and in their ability to perform activities of daily living. So any patients you have like that would qualify for some form of telehealth services. And also your patients who are at-risk patients for contracting COVID-19 if they were to go outside of their homes, specifically patients who are elderly over the age of 60, patients who may be immunocompromised or who have some type of an autoimmune disorder that would be where it would be very dangerous for them to get to the office, even with all of your precautions, you know. And I know that most of the providers that I'm talking to that aren't under a complete lockdown situation are taking extraordinary measures to safeguard their patients from contamination or cross-contamination infection, safeguarding their employees as well. And so, and everybody that I've been talking to is just doing a phenomenal job of that. But even in spite of all of that, there are going to be situations in which your patients just cannot come to you, where you may not have the option to having your patients come to the office. You are being forced, depending on the community that you are practicing in, you're on forced lockdown where patients are not allowed to come to you. And however, with a forced lockdown, that does not mean that you cannot offer telehealth services. You can actually offer telehealth services. So once you and your staff have sat down and you've identified a group of patients that you can get started with, and honestly, I'd probably stick with, you know, to get started and to work out all of the bugs, I would probably look at a fairly small sampling of patients, maybe 20 to 50 patients that you could identify that would qualify. And then what your staff needs to do is get busy calling these patients. Let them know that you are implementing a home therapy protocol for them because you know they can't get to the office, and schedule them for an online telephone consultation to get the process started. So there's going to be several different steps that you're going to want to take before you do that very first actual telehealth visit with the provider and the patient. The first thing you're going to do is schedule them for about a 15-minute online telephone consultation, okay? The next thing that you're going to want to do is, while you are identifying your patients, you're going to want to explore and choose the technology options that you're going to use to accomplish this telemedicine. And so, one of the things that I've discussed with several professionals, other consultants, for those of you who are listening in who are clients of advanced medical integration, Coleen and I had a discussion about this yesterday, and one of the things we talked about is we've got to make this as easy as possible for the patients. Okay, you're going to have some patients that don't have computers at home, that don't have a printer, that may not have any advanced technology, but they have a cell phone. Okay, and even the grannies out there know how to FaceTime their grandkids, right? And so if all you have is FaceTime, then that's what you're going to use. And so one of the things you need to look at is being very flexible with the technology. For some patients, it may be FaceTime. For other patients who don't have an iPhone, for example, or an iPad, it might be Skype. Okay, they might need to download a Skype app on their Android phone. And so make sure that you have different platforms available for the different types of patients and what their technology allows you to do with them. Okay, you might have patients who sit at their computer all day long and they love working at their computer. They have a webcam. And so they will go ahead. I'm going to just go ahead and mute everybody here. I've got some people who are unmuted, so let me mute all. Okay. For those of you who are coming on, if I'm muting everybody, if you do have any questions as I am doing this talk, please feel free to type your questions into the chat box in the GoToMeeting menu. And at the end of our conversation today, I'm going to open it up for a Q&A session as well. So your questions will be answered. Hopefully what we're doing here is through this webinar, we're going to answer a lot of the questions that you already have floating around in your mind, and maybe even answer some questions that you never even thought of yet. So right now what we're talking about is the technology and how are we going to, what platforms are we going to use? And I do think that you need to be flexible. I think you need to have different options depending on the patient. The next thing you need to talk about is there's certain paperwork that's going to have to be done in order to initiate a telemedicine protocol with your patients. So one of the things that I would strongly recommend, and very, very strongly recommend, is that if you have a software program that has EMR, okay, whether or not you're using the EMR itself, what you want to do is you want to make sure that you are that you. I think we have somebody who is not muted. Let me see. If you are not muted, could you go ahead and mute yourself, please? I would appreciate that. Okay, hopefully that took care of that. So if you are, you're going to have some paperwork done for the patient. And I am strongly recommending that you activate, if you are not already using a patient portal, that you activate the patient portal features of your practice management software program. This is very important because, number one, utilizing the patient portal is going to allow you to bill for certain types of services that you cannot bill for without a patient portal. Okay, so that's one thing, and we'll talk about that. The other thing is, hi, Juliet, I see that you've arrived. Please make sure you mute yourself for the meeting. So I would definitely recommend that you your patient portals activated. You know, we've checked with some of the big software programs like ChiroTouch and Eclipse. There are patient portal options that if you haven't activated them, you want to get with your software vendor and make sure you turn on the patient portal, because that's going to be the most secure way to get your documents to you. For those of you, I have a lot of clients who utilize the Office Ally technology, which is Office Ally with the Practice Mate program, and then the EHR 24/7 program. Office Ally has 2 free applications. One is called Patient Ally, which is the patient portal that's free to activate. And then there is also an option called Intake Pro. And actually what Intake Pro will do is it will take all of your forms and digitize them for you. So you can have them on the portal and have them as forms that the patient can fill out right on the portal. And that's one of the nice things about having a patient portal, is that you can usually get your forms onto the portal and have your patients fill them out through the portal and get them back to you through the portal. If you don't have the portal, or if you think it's going to take a while for you to get the patient portal up and running, you can go old school. I mean, you can email the forms to the patient. If the patient has a way to print the forms, then you could email those forms to them as a PDF, a group of PDF documents, have them sign the forms. And if the patient, worst case scenario, if the patient doesn't have the ability to scan those forms back to you or fax them back to you, then they could take a picture of the signed forms on their phone and then text them over to you. I mean, we need to get creative with all of this as far as, how are we going to get the paperwork and the consent forms over to the patients and the documentation that we need the patients to do for the for these services. So how are we going to get what technology are we going to use to get paperwork over to the patients? I mean, you may have patients that are very, very not computer savvy. They don't have a lot of they have maybe a smartphone and they know how to take a picture on their smartphone. You can mail them the forms. It'll take a day for them to get the forms, and then you can tell them to take a picture and text it over to you. Or you can mail them the forms, tell them to sign the forms, leave them outside their door, and somebody will go pick them up. I mean, again, you all need to really be thinking about and strategizing with your office. What are we going to do, and how are we going to get these pieces of administration done in order to initiate the administration of telemedicine? What technology are you going to use to take remote payments? Remember, you're not going to have the patient in the office to drop their copay off to you. So what are you going to do? I mean, there are a lot of payment application tools out there right now, like Venmo, Cash Now, PayPal, where a patient could do a virtual payment to you, one-time payment, or you could set it up as a credit card on file and place that credit card or an ACH debit directly from the checking account into a PCI compliant database such as Cash Practice. I know that ChiroTouch, for those of you who use ChiroTouch, they have a PCI compliant database to store credit card data. Eclipse has that as well with XCharge, and many of these software platforms. I think Office Ally has one called AxiaMed. So you have a lot of options there, but what you have to start doing now is exploring those options and figuring out for your own individual practice what's going to work best for you for taking remote payments. I mean, you can take a payment over the phone with the patient authorization. So it can be as simple as calling a patient and getting an authorized payment over the phone and having them verbally give you their credit card information. You can do that, or you can set up some type of a Venmo account or PayPal or something like that. So if you have questions about about how to initiate all of that, by all means, feel free to contact me and we'll be happy to talk about this and strategize this more with each of you on an individual basis. But what I'm trying to do now is I'm trying to get you all thinking about what steps do you need to take to get telemedicine going in your office. Okay, next. So the next thing that you might want to look at are remote patient monitoring apps. So one of the reasons why you would want to consider remote patient monitoring apps is this is a billable service, is monthly monitoring and routine monitoring of patient vitals or patient data, physiological data. And so I told you last week when I did my presentation that I was going to do a little bit more of a dive into this, and I have. I have found some super cool apps that are like either super cheap or even free, in which you could, using a smartphone, do remote monitoring of patient vitals. And so the next few slides are going to show you some screenshots of places. So this is from healthline.com. This is an article called Top iPhone Android Apps. This one was called Instant Heart Rate, had very, very good ratings. And then what you can do is it says the app records your beats per minute and has a note space to track what you were doing at the time of the test. And then that information can be then translated over to your office. If you are doing remote monitoring of patient heart rate, you might be doing that while they're doing their exercise. Have the instant heart rate monitor available so that you can make sure that their heart rate isn't getting too high. Remember, we have to look at the safety of the patient as we're doing these, if we're going to be doing exercise instruction with them, we want to periodically monitor their heart rate to make sure that they're not under any kind of physical distress. Here's a free blood pressure monitor, okay, that you can actually do on most smartphones, okay, and this is a free blood pressure monitor. Here's another one called Smart Blood Pressure, and these are both available on iPhone and Android phones. This one is very cool because not only does it do your blood pressure, but it calculates BMI, MAP, transform data into color-coded charts and graphs that then can be placed into the patient file for documentation of the remote patient monitoring. So this would be another great one to look into, recommending that your patients get onto their smartphone. Is the Smart Blood Pressure one. I checked into some companies that provide more sophisticated remote patient monitoring. I like this one, Foracare. This one was kind of at the top of the search engine, and for some good reasons, because they have very comprehensive set of products. Now, these are a little bit more high tech as far as the products. It's not using a smartphone. They actually provide blood pressure cuffs and different monitors for the services that you might be monitoring. And so if you want to look at what they've got, their website is www.fora-shop.com. And so these are some of the products that they have. This is a blood glucose monitoring system. So if you're listening to this and you're dealing with patients with type 2 diabetes and you're wanting to monitor their blood glucose, they actually provide the monitor that then transfers information to an app, and that then transfers it over to you and into your EMR system. Here's a blood pressure monitoring system. Again, this one is done with an armband. They have wristband ones, and they also have finger monitors. They have weight scales that do weight and BMI. Pulse ox and ear thermometers. So all of these are available as products that can be sent over to your patients for use for remote patient monitoring. And then what that does is, if you use a product like that, then the software is built in to automatically transmit those results to your office. And what FORA says is, under appropriate technical tactics and business associate agreement, FORA 24/7 will provide secured integration interface with your EHR or PHR system. So, it might be worth a call to them to find out what they have available. If you're looking for, let's say, physiologic monitoring of a patient's exercise program, you could contact them and see what kind of products they have available that would give you that capability with your patients. So why would you consider remote monitoring? It's not something you have to do as part of a telemedicine protocol. However, it does, number one, give you an added layer of protection. We want to do this responsibly, right? And so we want to show our malpractice carriers and our patients that we are not just getting on FaceTime with them and saying, okay, lift your arm, up over your head 10 times, and lift your other arm over your head 10 times, and let's do 5 squats. And I mean, they can do that with a personal trainer, right? We need to make this medical, and we need to make sure that what we're doing is being looked at as a medically necessary service. So it enhances the telemedicine services that you offer the patients. It protects you and it protects the patient. If you're telling a patient you need to submit a daily accounting of your, once a day, I want you to take your blood pressure and your pulse and transmit that over to us so we can monitor it. All right. That, number one, lends a lot more legitimacy to what you're doing. It also protects you from possible malpractice suits, and things like that. So the other thing is that the remote physiological monitoring services are billable, and there are CPT codes for remote physiologic monitoring. So you have a code for the initial setup. So once you have delivered that remote physiological monitoring system to the patient, or the patient has downloaded the app and you're going to train them on how to use it, you can bill this code 99453. Okay. And then if you're taking the daily recordings, okay, and you are, transferring those recordings into the EMR each day, okay, once a month, you can bill for that service of taking those recordings and then transferring those recordings into the EMR. Now, the fees that you see here are national rates for Medicare. This is what the Medicare allowable is nationally. These are just very, very loose reimbursement guidelines. Commercial payers may pay more than that, may pay a little less. You would just really need to, this is all so new for us. We're very, very, there's a lot of unknowns as far as how much you'll get reimbursed, but generally you could say that that you could probably expect to get your reimbursement somewhere, in or around those Medicare allowable rates. And again, this is something that can be billed. The 99453 can be billed once, or each time you provide a new remote physiologic monitoring equipment for the patient, you can bill that. The 99454 is the transfer of data, and then the 99457 are management services, 20 minutes or more in a calendar month, requiring interactive communication with the patient. So this is where you would set up a small appointment, maybe once a week, with the patient to go over their physiologic monitoring results and talk to them about, okay, we're noticing that, your blood pressure has gotten a little high, or we can see that you're not doing the exercises the way we've recommended, and you're having those small consultations throughout the month with the patient, then you can bill that 99457 code. So the next question that I've gotten a lot from providers who are thinking about implementing a physical medicine, telemedicine protocol in their practices is, what kind of equipment should the patient have at home? Now, really and truly, you don't have to have any equipment. But if you think about what you would be doing with a patient in the office, let's say you use TheraBands in the office, or you have the bands that, that are up against the wall, and you put, they have different tensile strengths to the bands, and they're using that. Maybe the patient is using a wobble board for neuromuscular reeducation, for improvement of balance and proprioception. Maybe you have some stairs in the office that you're doing gait training with, and you've got a little stair stepper or something like that. Now you have to take that equipment home, right? So you have to create a program in which you can simulate what you were doing in the office at a patient's home. And so I just did a bit of a dive into some of the basic exercise equipment that you could provide for your patients or have your patients get. And these are billable codes. Now, these aren't always paid by the insurance company, so you would definitely have to, when you're doing your insurance verifications, you would want to add these codes to the verification to see if these are covered by your insurance company. And so but they are readily available through Amazon to be drop shipped directly to your patients. If you have a Prime account, you can usually get them to your patients in 1 to 2 days for no cost. If it's not covered, it's usually something that a patient could easily afford out of their pocket. You could bill it to their, even if you didn't make a profit on it, you could bill the cost of it to the patients and have them reimburse you for the cost of the equipment. So again, something as simple as a set of bands, from all the way from 10 to 50 pounds, along with the straps, is $30 for a patient to get. Wobble boards, you can get a balance board or a wobble board for a patient for about $30 again. A gym ball or an exercise ball that a patient could sit on to do some of their rehab to make it a little bit easier for them. So, possibly if you have a patient that could benefit from having an exercise ball, again, these are very, very low cost. A stepper. Okay, so if a patient doesn't have stairs, they don't have a 2-story house where they have stairs, and you're wanting to do gait training with that patient, you could have the patient get a stepper, and then that stepper could be put up against a wall to where you could be doing some gait training with your patient using a stepper. And so, the total cost of all that equipment, if the patient got everything, it would be around $140. And not every patient is going to need every piece of equipment. You may have a patient that all they need are the bands, depending on the type of rehab that you're doing with them. So take that into consideration. You may have a supplier where you can get that equipment. If you buy it in bulk, you might even be able to get it less expensive, and then be able to just deliver it to, have it brought to your clinic and then deliver it to your patients' homes. And then just charge them for the cost of the equipment, using like Venmo or some type of a PayPal app or something like that. So it's not a very, very high cost of equipment. And you definitely you probably want to pass the cost of that equipment on to your patients, because again, your goal is to be able to bill out for these services. So if you purchase the equipment and you're already $140 in the hole, then it's going to take that much more before you can get this home rehab protocol to be profitable for you. So we've talked about the patients. What patients would you qualify for this home rehab protocol? We've talked about the technology. We've talked about the equipment. And now what we need to do is talk about the paperwork, which is, of course, everybody's least favorite thing to talk about, but very important. So you know, I've come up with a packet of paperwork that I think is important for every provider to utilize with their patients when they are going to be starting telemedicine. So the first is the patient consent to the use of telemedicine. And this is essentially an informed consent form that goes over the benefits and inherent risks of telemedicine, okay? The another form is if you decide that you're going to record these encounters through Zoom or GoToMeeting, which some providers want to do that. They want to record, have a visual recording for the patient, for both the patient to be able to go back and look at what, you know, review the instructions over and over again using a recording, which is a great idea. It also protects you and proves that you actually did that telemedicine service with the patient. It gives you a timestamp. If you're going to use that, you would want, and you are going to record any of the session, you would want to have a patient consent to record those sessions, okay? You also will want to have an enhanced consult form, which would be specific to telemedicine, a specific telemedicine intake and consult form. This would have specific questions pertaining to the telemedicine visits themselves. What type of technology does the patient have? Questions about the privacy of the patient's homes, and do they have a place where they could you could conduct the telemedicine visits in private, or is it going to be a semi-private area? And if it's semi-private, does the patient consent to having somebody else in the house while they're doing those telemedicine visits? Okay, a risk assessment. You know, I think it's important for you to ask your patients some very specific questions that maybe you haven't asked them in the past, like, have they recently fallen? So like in the last 6 months, have they had a fall, or are they at a risk for falling? And if you, and that first of all helps establish medical necessity. If the patient has had a fall or is at risk for falling, it establishes medical necessity for rehab. But it also will protect you, because then what you'll do is you would put that as an ICD-10 code on your claim form that the patient is either had a recent fall or is a fall risk. And so in the event you do a telemedicine visit and the patient does fall and injure themselves, then you have already you've already discussed this with the patient and given them informed consent about that. Okay. For an established patient under active care, this might be an addendum form to their current history. So you're going to review their current history with them and then add the telemedicine intake or consult form to that. For a reactivated patient, you would use your current intake form plus the telemedicine consults. You would want to redo that history, make sure the patient updates their history so that you have the most current information plus the telemedicine consult form. And then the other thing you're going to need are insurance verification forms that are reconfigured to questions about telemedicine. And so all of these forms, I've developed these forms for you, and I will have these available to you as a packet of intake forms that will be in a, this is just an example of the informed consent for telemedicine. And you can see that, you know, it talks about what telemedicine is and what it does, what the expected benefits of telemedicine are, what the possible risks are, and a patient's understanding of the benefits and risks to telemedicine. And it gives the patient consent to the use of telemedicine. This is a super important form for you to have before you offer telemedicine services to your patients, okay? And so I will have this form available, as well as all of the other intake documents that I just discussed with you. All you need to do is send me an email, say, hey, I took your webinar and I'm interested in getting a packet of those intake forms. I'll be sending them out as a Microsoft Word document, which means they They can be manipulated. You can add, for example, your logo, your clinic logo up at the top of the forms. You can change words like, you know, where it says, at the bottom of this consent form, it says, I hereby authorize, and in parentheses, name of provider. You can actually put the name of your provider in there. And so you'll be able to customize these forms for your own particular situation. So again, I'll have my email address at the end of this presentation, as well as, you know, it's right here, so you can take a screenshot of it. I also have this presentation available in handouts in a PDF format. So if you want the handouts for this for your office to go over with your staff, then by all means, please send me an email, and I'll be more than happy to send you the handouts for that. So, okay, so all that said, all of this needs to be done and needs to be accomplished before we even schedule the first appointments. But once we have all of the pieces in place, the paperwork, the technology, the equipment that we're thinking we're going to use, and so on and so forth, then it's going to be time for us to start reaching out to the patients to schedule those initial appointments. And the first appointment that you're going to do is something called a virtual check-in. The code for that is G2010. Now, what I'm finding is that we've been doing some insurance verifications. We're finding that even though this is a Medicare code, many commercial payers are covering this code. And this is where the patient is, you're going to schedule a time where the patient calls you. Now, I want you to think about this. In a regular office visit, the patient comes to your office. In a telemedicine visit, the patient comes to your technology. So for the first appointment, the patient calls in to you as if they are coming to your office, right? I want you to think about it that way. Or they will initiate a FaceTime or Skype visit. And this is when you know, I said, like in that, in one of the earlier slides, that you identify the patients, you call them, and you schedule them for that first appointment. Well, this is that first appointment. And so you're going to, during that initial phone call, your staff is going to say, okay, here's what you need to do. And you might even put those instructions into an email for the patient and let, you know, so that they have some type of a document to follow, because they may not remember what they need to do. They may be waiting for you, but you need to let them initiate this appointment, okay? Because by their initiation, you can then bill for it. So the patient calls in or initiates a FaceTime or Skype visit. You give the patient your information so they can do the initiations. And during the virtual check-in, this is where you'll go over the telemedicine intake forms. You'll update their history, pull, if they're under active care, you're going to pull and review the current patient's history, treatment plan to see if there are any updates needed, supplement the history with the telemedicine intake form. And this can be done by your ancillary staff. So the same way ancillary staff can record history in an E&M code or an office visit, your ancillary staff can perform and help you perform this virtual check-in. So this isn't something that the provider has to do. Then what the ancillary staff would do is, after they've gathered up all the paperwork and gotten that done, or at least shown the patient where they can go into their portal to get the paperwork, given the patient instructions on how to access their patient portal, that can all be done at this virtual check-in. And so once you've done that, then you're going to finish the appointment up with a schedule for the first telemedicine visit with the actual provider. And so the next visit is going to be telemedicine visit 1, which is going to be your virtual exam. And this is going to be an office visit code, like your CPT code. If it's a new patient, 99202-203, it's going to be somewhere in that range probably. For a new patient, 99212 or 213 for an established patient. The provider will initiate the FaceTime or Skype visit. The provider will then review and document the history recorded by the patient and the ancillary staff, the same way you would if the patient was sitting in the office. So if your ancillary staff records history in a face-to-face office visit, then they would provide you with that history. You'd look it over, you go into the patient treatment room, and you would review those pertinent positives and negatives in the history, like the review of systems and the history of present illness, that type of thing. So all of that is done virtually now. You would do that with your patient. You would perform a visual exam and verbally directing the patient what they need to do. Maybe you would want them to take their temperature, take their blood pressure, take their height, their weight. You could do that. You could and have them call those results out to you, or show you, if you already provided them with a pulse oximetry unit for their pulse ox and their their pulse and pulse ox, then they could hold it up to the camera and you could see it and you could record that. Okay, and then at that point, after you have done your exam, you would make a recommendation for further treatment to include possibly a functional exam. So for those of you who do functional medicine, if you have a patient under active care and you're just moving them over to telemedicine, you may not have to do a functional exam because you've already done one with them. But if you haven't, you may want to schedule a functional exam with that patient, and that functional exam is going to include things like range of motion testing, visual range of motion testing, other types of functional assessments that you can do verbally and visually with the patient. You would make any recommendations for any DME that you feel would be beneficial for the patient, and then a separate appointment with that patient and your therapist to show the patient how to use the DME that's being recommended. During this visit, at the end of this telemedicine visit, the provider would dismiss themselves. The ancillary staff would then come in and do a visual financial report of findings with the patient, okay, on what you found as far as what their insurance verifications stated as far as the telemedicine visits, if they are going to have any out-of-pocket costs for their exercise equipment and that kind of thing. And so it's important for you to have that discussion with the patient during this first visit to let them know that, we do have options for you to pay your co-pays online. You can ask the patient, have you ever used Venmo? Do you know how to use PayPal? So again, the same way you give them options for the telemedicine visits themselves, you may want to give them some different options for how they would pay their bill for any of their cost share or their out-of-pocket costs, okay? And so this would be encompassing that first visit. It would be like your day one. And then your second visit would be your functional exam. And so this would be where the provider initiates a FaceTime or Skype, performs portion of the functional exam that can be done visually, directing the patient verbally, might include a review of the functional assessment tools. You would have patient fill out, let's say an oswestry or a neck disability index, whatever you're using currently for outcome assessment tools to measure functional, performance and to set your baselines. You would want to be able to have as a form for the patient to do virtually. Review of any equipment that might be used for the therapy session. So, you would probably want to do this exam after their equipment has been delivered to them. Schedule them for a time to, tell them to let's pull those bands out. Let me show you how you would, how to put them together. Let's show you how to use them. And then you would, at that point in time, after that, you would begin to schedule them for the actual therapeutic procedures. The most common ones that I can envision seeing under the telemedicine services would be the therapeutic procedure, code 97110, gait training, 97116, and neuromuscular reeducation, in rare cases, 97112. Each of these are billed by time in 15-minute increments. You would initiate a FaceTime or Skype. the provider would instruct the patient on the actual activity, watch the patient perform the activity correctly and safely, and then document the specific activities that were done, the number of repetitions, and the amount of time spent, as well as observations about how the patient did, whether they were, struggling with it, whether they were successfully performing the exercises, or have they been in compliance with doing their exercises in between visits and things like that. So all of that, your documentation requirements, I'm just going to say, doing telemedicine, if you're not really good with documenting in person, you're going to have to really improve that process, because right now this is all so unknown as far as how insurance companies are going to respond to these telemedicine visits. Okay. We have the law on our side. We have the regulations on our side that say we can do this. But that doesn't mean that when all these telemedicine visits start hitting the insurance companies, that the insurance companies are going to want to start auditing what you're doing. And so your documentation of your telemedicine visits have got to be extremely thorough and extremely specific as to what you're doing with these patients. Okay. Now I have had some questions about whether therapy assistants can perform these telemedicine visits. The guidance that I have gotten and what I have heard is that for the commercial payers, it is based on the same guidelines that the providers have under their scope of practice. So if, for example, a chiropractor in your state can direct a CA or a certified CA to do the therapy services, you could bill under that direction and supervision, meaning and direction and supervision means that the provider is in the building, has immediate ability to step in and supervise that patient. What I'm hearing is that it is going to be based on scope of practice for the states for commercial payers. Now, Medicare is different. Okay. Under Medicare, the Medicare rules apply for application of physical therapy services, which means, remember that under Medicare, the only thing a chiropractor can do are spinal manipulations, and spinal manipulations are off the table as far as telemedicine goes. You can't virtually manipulate a patient. You would have to do a home visit for that, which I will be doing a webinar next week on home visits, if that's something that you're interested in. But you can't do, for Medicare patients, really all you're going to be able to do is offer them these types if you're just a chiropractic office and you're not a medically integrated office, the only thing you'll be able to do with your Medicare patients are these services as cash services, and maybe have some type of a cash plan for them, a treatment plan where they could maybe pay this out over time or whatever. And it is definitely unfortunate, but that's the reality of it, as a chiropractor. Now, if you're a medically integrated office and you have a nurse practitioner on staff, then it is based on the scope of practice of the nurse practitioner. And each state has different rules as to whether a nurse practitioner can render physical therapy services under Medicare. Some states absolutely categorically no. Other states, yes, and some states, so you're just going to really have to, identify and know whether your state scope of practice allows for that nurse practitioner to do that. Now, under the Medicare physical therapy rules, and I have that documentation to provide to you if you want it, it states that a provider or a non-physician practitioner may supervise physical therapy as long as it falls under their scope of practice, their state scope of practice. So again, if the state scope of practice allows for a nurse practitioner to provide the physical therapy services for Medicare patients, then the nurse practitioner could then follow the rules for supervision, which for Medicare is direct line of sight. So that means that the nurse practitioner would have to be in the room with the therapists under direct line of sight. And you know, again, telemedicine, how are you going to prove that? You're going to prove that by having the nurse practitioner come by, you know, every so often and supervise that session visually so that you can prove that that nurse practitioner was in direct line of sight. So, you know, you may have three therapists, you know, all on FaceTime doing, you know, therapy on 3 different Medicare patients, but you've got to make sure if you're medically integrated and you're allowed, and the nurse practitioner is allowed to supervise under their scope of practice, that you do that correctly. Okay. And if you have questions about that, you can contact me and we can research that a little bit for you. There are websites that we can go to look up the state scope of practice rules for the nurse practitioners and the PAs and the medically integrated practices. So the final questions that I have had on this are, how are the services billed out? So your virtual check-ins, your remote physiologic monitoring codes, and your e-visits have their own set of codes. The telehealth visits themselves will be billed with the CPT code you normally use, but you would change the place of service from 11, which is office, to 02, which is telemedicine. Some commercial payers are requiring a 95 modifier on the CPT code to indicate that it is a telehealth service. Medicare is recommending that modifier but does not require it. So Medicare only requires that you change to place of service 02 for your telehealth services. Your commercial payers, you're going to need to know what their guidelines are, okay? And so if you look at what some of these online digital evaluation and management services are, this is actually a little bit of a review from last week, but you have these 3 codes, 99421, 22, and 23. Now these can be done in addition to your telemedicine services that the provider is doing. And this is where the patients will send in questions or queries through their portal, which again, this is why having a patient portal activated is so important, because these are codes that are based on patients submitting queries through their portal throughout the course of their treatment plan, okay? So they can submit the data of the remote physiologic monitoring. They could submit questions about their exercises, queries about, you know, is there anything else I can be doing? And the provider, not a staff person, but the provider would respond to these queries, and the amount of time that it takes over a 1-week period, the cumulative amount of time is how you would bill the code. So if the provider spent 5 to 10 minutes interacting online with a patient over the period of a week, you could bill out of 421. If it's 422, it would be 11 to 20 minutes. 423 is 21 or more minutes. And these are codes that can be billed once a week, every 7 days. As you are interacting with your patients. So one of the things you're going to want to do is really encourage your patients to interact online and digitally as much as possible. Part of it so they don't feel so isolated, so that they're having continual communication with you. And so depending on, you know, the amount of time, that is how you would want to bill out these online digital E&M services. Now the reimbursements for these, Medicare, it's about $15, $30, and $50 respectively every week that you could bill out, you know, depending on the amount of time that was spent for those online digital E&M services. Now, the documents, I'm going to encourage all of you to start armoring yourself with documents. We're already doing this as a company, and for those of you who don't know, you know, again, my name is Lisa Maciejewski. I'm the owner of Gold Star Medical Business Services. We do remote billing for doctors all over the United States. And so for our clients who are, our clients where we're doing your billing for you, we are gathering up all of these documents. Your biller is gathering up these documents for the payers that we're doing business with for you, so that we have the kind of the green light from the payers as to what is covered under telemedicine services. So you want to have all the documents that you can find pertaining to telemedicine billing during this COVID-19 national healthcare emergency, because if your claims are denied, these documents will help you with your appeals. I would recommend that you have at your fingertips the CMS fact sheet that I showed you earlier in the webinar, the OCR FAQs that tell us that the telemedicine services such as review of physical exercises are appropriate to bill for telemedicine services. So in the event the insurance company hasn't gotten the memo and they deny that 97110 saying that's not authorized for physical medicine, we can appeal it with these documents, okay? And then also any payer guidelines that you can find for your commercial plans. This is just an excerpt that I pulled from Cigna, and this is what Cigna tells you can how to actually file the claims, what the place of service code is. Cigna tells us that they want that 95 modifier on the telehealth services. Some payers do, some payers don't. So, the good news is that if we're doing your billing for you, it's going to be, we're doing all of that research for you, and you don't really have to worry about it. But if you're doing your own billing and you need help, with these guidelines, where to go, please feel free to give me a call. All of these guidelines give you all kinds of resources that you can pull from. So there's additional resources. For example, on this one, it has a link to the American Telemedicine Organization. And I mean, it's all out there for you. You just need to find it and gather it and have it available in, those are your little insurance policies in the event that the claims for whatever reason are denied. Finally, if you need any help, this is what we're here for. Our Gold Star clients, if you're listening to this webinar and you want to pull the trigger on telemedicine, we're ready to help you. You just reach out to your account manager or myself, and we'll schedule a consult with you and myself and your biller to discuss the implementation steps. And there's no additional fee for that. It's included in your billing service, so you don't have to worry about paying us extra to do that. Now, if you're a guest of this webinar, or you're not a client of Gold Star, contact me. I will be more than happy to do a complimentary consultation, 30-minute consultation, to point you guys in the right direction, to help you get the ball rolling. And if you want us to help you with additional implementation, then we can talk about your options there. You can call me at toll-free at 866-942-5655, or you can email me at lmajeski@goldstarmedical.net. Okay, well, this concludes our webinar, our presentation.
Hi, everybody. It's Coleen Carberry. I'm back again after listening to Lisa Maciejewski. Wow, that was incredible data. I know, extremely valuable data. As I said when I started this session, we have a practice in Chattanooga, and that practice in Chattanooga, wow, they're going to use that data. It's super valuable. My wheels are already turning on how I can implement some of the steps that Lisa just spoke about in our practice. So I wanted to thank everybody for coming today. Super valuable information. And I just want to remind everybody that this is something that we're going to be holding each evening, Monday through Thursday evenings, 60 to 90 minutes of relevant content that we can bring to you that's going to help you to be able to continue to bring care to your community. And we're also going to be bringing you some relevant content on some speakers that are just going to be inspirational to see what's happening on other fronts in the United States during this crisis. So thank you again for joining us. I want to remind you, tomorrow night, 5:30 Eastern time, we'll be back again. Lisa's actually coming back. We're going to actually get really close into telemedicine, how it relates to delivering back bracing and knee bracing to your community via telemedicine. Really super interesting. I did have a conversation with Lisa. She's going to be giving us all the nuts and bolts tomorrow. Again, thank you so much for joining us. See you tomorrow night. Bye. Have a great evening.